Hello everyone, welcome back to Hot Seat. I'm Omid Moghaddas joining you from Tehran, and once again I'm so grateful to have this opportunity to share with all of you from around the world from this platform the latest, the thing that we should know in our practice, especially in implant dentistry, periodontics and prosto, with great leaders from around the world. And today I'm so honored to have one of the true educators and true leaders, one of the biggest names that we all know in the field of implant dentistry and periodontics. Dr. Homa Zadeh from California is here with me. Hello, Homa, and welcome to Hot Seat, my friend. Thank you for accepting the invitation.
Hello, Omid. It's a pleasure to join you. I know that you've attracted a lot of great people and doing great work. So congratulations on all your amazing work to share the information for all the colleagues around the world.
Thank you, my friend. It's my pleasure that you accepted invitation and are joining me in this event and all our dear colleagues from around the world. Well, for all of our audience, you know, Dr. Zadeh really doesn't need any introduction. He's truly one of the best educators that we know in the field of perio and implant. And, you know, the way that he teaches, the way that he lectures, no doubt is on the top, because the way of he explains and the way that he shows you the details and give you the clues, the keys that you should know. And you know, I can talk about his perfection like 24 hours a day, so I won't wait you much longer. But before we start and go to his amazing presentation on periodontal and pre-implant plastic surgery, I would like to have his CV as a tradition for all of you, and then we will go to the presentation, and at the end we will have a great discussion on this amazing topic. Dr. Zadeh is a diplomate of American Board of Periodontology and fellow American Academy of Aesthetic Dentistry. He received his Doctor of Dental Surgery degree from the University of Southern California Ostrock School of Dentistry, also completed advanced clinical education in periodontology and earned a PhD degree in immunology from University of Connecticut, Schools of Dental Medicine and Medicine. Dr. Zadeh is internationally recognized for his clinical and scientific expertise. His clinical areas of interest range from aesthetic and minimally invasive periodontal and implant surgery, as well as tissue engineering. He served as the president of the Western Society of Periodontology in 2017 and directs the VISTA Institute for Therapeutic Innovations with blended educational pedagogy on a variety of clinical relevant topics. He also maintains a private practice limited to periodontology and implant surgery in Southern California. Once again, I'm so thrilled and grateful to welcome you, Homa, and really looking forward to this beautiful presentation and looking forward for the discussion at the end.
Thank you, Omid. I appreciate the introduction. I'm happy to share this information, which I think is relevant to many colleagues with different disciplines in dentistry, because it deals with managing aesthetic and health aspects of tissues around teeth and implant. So when it comes to periodontal plastic surgery, we manage many problems that exist around teeth, such as gingival recession. Periodontists typically spend a great deal of our time managing this really very common problem of gingival recession defect. There's also problems with vestibular depth and also contour deficiencies in sites with teeth or without that we need to correct. Around implants also, we have many problems that are mucosal deficiencies around implants, or implants that are incorrectly positioned, extraction socket management, and implants that have exhibited mucosal recession around them. So we have many soft tissue deficiencies that we need to correct, and periodontal and peri-implant plastic surgery are methods to correct them. So talking about gingival recession, there are three key types of protocols for periodontal plastic surgery. Perhaps the most common one is the coronally advanced flap. Coronally advanced flap is where most of our information is on. Many studies have been done on that. So that's basically is considered the gold standard just because of the level of evidence that's available for root coverage procedures with this. But when I think about plastic surgery in the true sense means that we have to be dedicated to preserving the blood supply. We have to be dedicated to not having any scar tissue. So when we're making incisions in the exact areas that we're trying to correct, neither one can be, because you're going to be compromising the blood supply as you're making the incision right in the surgical area that is being corrected. A plastic surgeon will never put incisions on the face to do a facelift. All the incisions are made remotely. So in that sense, the intracellular tunneling has been developed, and starting with the 1986 with Ratsky, and then later Jan Zabelegi and many colleagues, and later Pat Allen and Tony Scullion have really worked a lot to try to minimize mucosal surface incisions, to try to access the sites through sulcus of the teeth. So this is more consistent with plastic surgical principles because it minimizes surface incisions. Nonetheless, this is quite challenging. To try to go through a sulcus of every tooth is a very difficult proposition. So with VISTA, we've tried to have respect some of the principles of plastic surgery, which are preserving the blood supply and making our incision remotely. So the incision is typically made under the vestibule in a vertical direction as a way of giving a better access to try to mobilize the tissues, to try to reposition them. And it also gives us better access to place larger types of tissue grafts that are necessary, especially with some of the scaffold material that we are using today are quite large, and we need to increase the mucosal thickness through this. So I'll take you through one case just to illustrate the specific protocol for VISTA. And we can see in this case is a Miller class, I would say 3 or Cairo RT2, where there's interdental tissue losses as well as midfacial tissue loss. There's a restoration on the canine on both the left side, and also a very bulky crown on the right side. And as a result, there's quite a bit of recession. So with VISTA, standing for vestibular incision, subperiosteal tunnel access, first determine what is our target. Our target is to bring the tissues at least to the level of the CJ. So that's the area of recession that we have. So these areas, we will do some root instrumentation that I'll do with you a little bit more detail. And our surgery starts with vestibular incision, a vertical incision in the vestibule to give us access for the subperiosteal tunneling. So the tunneling is a full thickness dissection. This is also consistent with plastic surgical principles, because if you keep the mucosa and periosteum together and not separate the two with this type of a subperiosteal tunneling, we're preserving the blood supply best. And you notice that as we're doing these manipulations, the blood supply to the tissues are relatively intact. And we extend our tunneling under each of the papillae. And one important aspect of any kind of root coverage procedure is odontoplasty, we have to remove the excessive prominence of the roots. So the root prominences have to be managed by flattening the roots and reducing their prominences. And we create kind of a concavity. We remove all restorative material from the CEJ above to make sure that we don't have any kind of a material that's over the roots. The same was done with the restoration, even though it's a crown, a PFM, and we have a risk of exposing the margins. We inform the patient that she may have to remake the crown. So odontoplasty is done. The roots are flattened, and you can see that the root was pretty prominent with the restoration, very bulky restoration. So what we've done is to flatten the root. Now the root is entirely within the gingival housing, and that's our goal, is to bring the root within the gingival housing so you can appreciate how much reduction we've done. And the same thing was done on the contralateral side, and the root was made flat, and that bulky restoration, the composite, was reduced. So we've gone through these steps of subperiosteal tunneling. The next critical aspect with VISTA is coronal advancement and bonding the gingival margins of the teeth with these bonded sutures that are coronally advanced and bonded with composite restoration to provide stability. One very important aspect, because many colleagues use VISTA, but they don't go through this step of coronally advancing and bonding. They say, well, it's too difficult. I became a periodontist, so I don't touch composite, or, I don't have a light cure in my office because I just do surgery. Well, this is actually a very important step. And I can tell you, once you learn it, it's actually easier than the sling sutures that are typically used. But what is unique in this is not just the suturing, it actually puts the gingival margin position within the hands of the surgeon. So you as a surgeon can control exactly where you want the tissues. So you can see that the midfacial is brought to the same level as the interdental. Okay, and that's really very important. That's one aspect. But equally as important is the space that is created. When you bring the tissues down and you bond them, you're creating a space, and if you measure that space, is somewhere between the alveolar bone and the mucosa. So the space that you're creating is a very stable, protected space. And that's really the principle of any regeneration. So if you want to regenerate bone, you'll create a protected space within which you can create bone. Here, we're creating mucosa. We'll create a very protected, stable space. In that area, we will fill it with some kind of a scaffold that's appropriate for tissue regeneration, and that space will fill in. So in this case, we will look at how we've done with this kind of a coronal advancement and bonding. We can see that the papillae are very intact. If we were to do our manipulation through the sulcus, all of those areas will be ripped. Well, with suturing, sometimes you can see that we are putting a little excessive tension there, and we are cause a little bit of ripping. So that's something we should avoid. So that part is not ideal. Here, we see a little fold in the papilla. We didn't quite elevate the papilla as much, so we still have an opportunity to go back and make sure that we elevate it. And this is what we're looking for. We're looking for the papilla to be fully elevated and be at the same level as facial, that way creating harmony. And Having that large vestibular access allows us to place a very thick and large graft. This is typically a thick format of a cellular dermal tissue. A cellular dermal matrix, many people who are going through the sulcus, they use small pieces of it because there's not enough access. By creating the vestibular access, we can place a large one. And once it's in there, it's going to be very stable. Okay, you can see that we actually are put it in position, and it helps to support some of these spaces, and so the space is not going to collapse. Next thing is, can we improve those interdental tissue losses because we had tissue loss? So when we have generalized recession, I usually like to use some kind of a scaffold, either a dermal matrix or collagen matrix, as a way of filling that space. Here, I also like using very frequently the tuberosity as a donor tissue. Tuberosity is much different than palatal tissue. Palatal tissue has a lot of pain associated with it. The tissue has a lot of glands. It has a lot of fat. It shrinks a lot. Tuberosity is very stable. So I like using tuberosity because it's always, it's often there unless the patient has a third molar, and it's very thick and fibrous tissue. So I took the tuberosity, de-epithelialized it, remove all the epithelium, and divide it into 3 pieces. And each of those 3 pieces are inserted in between each of the papillae to create some bulk in the interdental tissue areas that were lost. So we're using lasso suture technique to bring each of those small pieces of tuberosity in the interdental spaces to bulk up those areas. So you can see those were sutured interproximally, and the interproximally sutured papilla is also coronally advanced and bonded. So these sutures of bondings typically remain for 3 weeks. That's how long it takes for the tissues to adhere and become strong enough that we don't need to keep them in place. So the patient comes back after 3 weeks for suture removal. And then we follow the patient. I believe this is after 6 months. We see that we have complete root coverage. We've covered areas of the roots where we remove the composites from. We covered the area of the root where we removed restoration. About 4 millimeters of the roots were exposed above the restoration. And it appears that we've filled in the interdental tissues, nice papilla fill. Okay, so we can see that we've also gained a lot of tissue thickness, and that is attributable to the suturing technique for VISTA to create that protected space. And you can see that this mid-facial tissue thickness gain. This, by the new American Academy of Periodontology definition, is referred to as phenotype modification therapy. So, my dear colleagues, we have 2 goals, major goals for, actually 3 major goals for periodontal plastic surgery for treating gingival recession. And they are, number 1 is phenotype modification therapy, which is to increase the tissue thickness, because thin phenotype is the number 1 risk factor for progression of the recession defect. The second goal is to harmonize the tissues, to have better harmony. Initially, we had lots of irregularities that are not aesthetic. And I would say the third objective is to cover roots of the teeth. Okay, so covering root coverage, I would say, is number 3. It's not the number 1 objective, because people always think of periodontal plastic surgery as root coverage. Root coverage is not necessarily it. I think phenotype modification is more important because it manages a very important aspect of the risk. So as we explain to our patients, we will explain in that particular order to always go for phenotype modification. So we can see after 6 months, we have complete root coverage. We even have interdental tissue fill. But it's very important to follow the patients up for longer period. You can see this is after 3 years. We have the mid-facial tissues that remain. In fact, if you look at the area of where we had the restoration, we actually had creeping attachment. Now that restorative margin is completely covered. So the tissue mid-facially have actually come down even further. But the interdental tissue fill was not complete because initially we have some tissue remodeling, and after that you can see we've created a lot of bulk. The tuberosity tissue that we placed created the bulk, but it does not necessarily fill the full embrasure space. So if you want to fill the embrasure space, the key is going to be orthodontic therapy. I think that's the best way. And in this particular case, the general dentist who was managing this patient as a primary care provider, she did a little bit of interproximal reduction and reduced the size of the embrasure to get some fill and bonded these teeth palatally. So interproximal reduction may be used in conjunction with root coverage procedures. So if we look at VISTA as a protocol, we have to be very clear about the advantages that are preservation of the blood supply. By making the incisions remotely, by creating a subperiosteal tunnel, we are preserving the blood supply. And we also have very good access for releasing the tension, because if you're going through the sulcus, you're going to release the tension just near the gingival margin. But a lot of the tension comes from further up where we have muscle attachments and much more access is provided through the vestibular access of VISTA to give us this tunnel release. We also have a very good access for larger grafts and matrices. So this is very important because if you're committing to phenotype modification therapy, you want to put large enough graft to increase the mucosal thickness. The stability of coronal positioning is very important because we're creating that protected space that is very stable. And if you want to regenerate tissues, you need stability of tissues. If you're trying to create bone, you can't create bone where the bone is shifting around, okay? The same thing is true. You can't create tissues if the tissues are moving around. So stability is very important. And then the scarring is very important because we create scar, but it's in the vestibular area. It's not near the gingival margin. So that's another benefit of this procedure. But we also have to be very realistic and transparent about talking about disadvantages. I would be the first one to admit that this technique is moderately challenging, okay? So it is something that requires a learning curve, just like any other procedure, but I've taught hundreds of people or maybe thousands around the world with this technique, and people are using that, and there are many great educators around the world who are teaching this technique to colleagues. So I would encourage that because this is something that is very much learnable, and it is something that with the learning curve, you can learn to perform that. The only limitation is when you have really tight embrasure spaces where there's really no interdental coal area. That's going to be something areas that we have to be careful because those papillae could not hold their tension. Also, if you have inflammation in the papillae, they may not hold the tension and they may rip easily. So when we first published about VISTA protocol in 2011, this is one of the patients who was in the case series in that paper. You can see major recession defect. And in this time, we created a vestibular tunneling. And at the time, the collagen material that we had available was a collagen membrane. Now, people have mistaken that and using membrane for tissue augmentation. Well, the way that we described the biomaterial that we use was not really the same way as I showed you with the last case that I showed you, which is to do phenotype modification therapy. Here, the protocol used was more like a guided tissue regeneration, because when I place this barrier membrane in there, in the subperiosteal space, in the space between the bone and the membrane, that area replaced a growth factor, platelet-derived growth factor, which at the time was in a tricalcium phosphate or TCP matrix. Today, I would not use that. I don't think there's much value in that. Today, I much rather use a natural platelet-derived growth factor in the form of PRF. But many people have adopted this collagen membrane as a way of tissue regeneration, which I do not recommend today. I think we have better matrices that we can use today. This is about, I think, 16, 17 years ago when I carried out this case. So you can see that the reported case that was presented in the paper was a 6-month follow-up. This is a 10-year follow-up. He has been now, I think, 16, 17 years out, maybe. Yeah, so I just don't have his documentation, but the tissues have been relatively stable. So we have to think about material that we have for our use. We have the connective tissue graft. We have the, that either comes from the palate or the tuberosity. We have different scaffolds today. I think these are essential for our work, because if you want to commit to phenotype modification therapy and we're going to do large areas, it's not rational to take tissue from the patient for the entire arch. We have to use either acellulodermal tissues or collagen matrices that, and in different parts of the world, there are different types of these matrices available, but these are the ones that have had publication track behind them. The growth factors that have been utilized, such as enamel matrix derivatives and PDGF, we are still using them, especially the enamel matrix derivative. There's some value in that, but increasingly we're using natural growth factors in the form of platelet-rich fibrin with the scaffold. So we are thinking in these cases that have recession defects. You can see this patient has kind of severe recession defects, primarily in the premolar and canine area. Maybe the anterior area has a little bit of recession, and you can see it goes all the way to the molar region. So when we're treating these patients, we can think of them as locals, but I would say that if you're coronally advanced in just the posterior area, then you're going to have really short teeth in the posterior and long teeth in the anterior. It's not really aesthetic, but also we haven't done fully what we need to do to manage this patient. So I think of these as full arch cases. This patient, basically, I would never treat the central incisor or lateral incisors if that's all the patient had. But if I'm treating the posterior region, in this case, I would just go ahead and connect the two. If you have a vestibular tunnel, it's just as easy to connect them all across and harmonizing the tissues. Harmonizing the tissues is very important. So what we use for tissue graft, I like to always use the tuberosity as a donor tissue material because it is very effective, but it's small. You can just use it in the most critical areas, which in this case were the premolars. And then I would always use some kind of a scaffold, in this case an acellulodermal matrix scaffold, to use it across the whole arch. And then we also today we're using PRF, platelet-rich fibrin, as a biological agent to slowly release growth factors, enhance the healing process for us. So this is really, I think, very helpful. And we are also treating the mandibular area as well. So we are able to treat basically these patients as full arch or full mouth and trying to take care of this and put it behind the patient. So you could see this is how the patient came for follow-up, and you see we have really harmonization of the patient. Okay, so you can see that think of these as more broadly comprehensive, and that's going to be much better in terms of a management of these cases. So when we're treating these patients, I just want to show you a large collection of these cases, just so you can get an idea and appreciation of what it is that we're accomplishing for these patients. So I will show you a big collection of it because it's important to see the good cases and the bad cases, because when we are treating in private practice, we have all kinds of cases. And this is a large collection of my cases. So you can see the before and after with acellulodermal matrix, tuberosity. You could see various materials. So I'll just show you, a large collection of these before and after, with some shorter term, 6 months, some 4 years, 3 years, 1 year. You can see these cases just to kind of get an idea what kind of outcomes we anticipate with this. So you can see this is a pretty large selection of cases with different biomaterials, with different duration, some of them around implants, some of them around teeth, just to kind of get an idea of what we are seeing with these cases and what we can expect for the cases. Some good, some not as good. But you see, all in all, this what you saw were 75 patients, 344 teeth. And in these cases, we had a mean of 4 teeth per patient that we treated. And you can see that RT1, these are the ones that have intact interdental tissue, are about half of those cases. The other half is mostly RT2, the ones that have interdental tissue loss. Fewer cases of RT3 that are the severe interdental tissue loss. The mean follow-up of these are being prepared for publication, are 33 months. And the range of follow-ups is anywhere from 3 to 120 months. So I would, with these cases, we have followed them up over years. You can see this is what we are getting as a percentage of root coverage. Percentage of root coverage is very important to see that, but what you see is that we're starting just below 100, but over the first 2 years, we actually get increase in root coverage. As you saw in the last case that I showed you, you actually get creeping attachment. And we get it consistently. It's not just occasionally. We see it consistently. And the reason we see that is because we're creating this thickness gain, and we are creating this concavity over the roots. So this is a more or less consistent phenomena. We are getting some decline over time, but you see it hovers somewhere around 100%. So on the average, we're getting close to complete coverage. Now, it doesn't mean every case will get complete root coverage, as we don't. Now, one important aspects that was pointed out by Alfonso Hill, who's right now at the University of Zurich in Switzerland. He's pursuing a pros training, but he used this project for his master and PhD theses. And what Alfonso did was to superimpose before and after of these clinical cases that were done actually by private practice of root coverage using VISTA. I think the most important thing that Alfonso found was to look at the root prominence. When you're looking at the side view of the roots, because he was using 3D imaging technology to quantify, he was able to quantify and measure how much root prominence existed. And you can see that he was able to measure that. And what he found was that there was an inverse relationship between root prominence and root coverage. The more prominent the root was, the less root coverage. So you could see some cases had low root prominence that were less than a millimeter root prominence. Some had more than a millimeter root prominence. So you could see that the cases that had very low root prominence, our mean root coverage was 110%, more than 100%. Because remember, we are coronally advancing beyond the CEJ, so we can achieve more than 100% if the roots are flat. But if the roots are more than a millimeter prominence, those cases we only can achieve 70%. That's why I suggested when you have these very prominent roots, we do odontoplasty to flatten the roots. If the roots are really prominent, like you see here, these are the cases for ortho, to do some torquing of the roots to bring them within the alveolar housing. So this is very important observation. So what we do is eliminating root prominences with odontoplasty and creating flat surfaces. As long as you can create a flat surface, you can cover these roots with root coverage. So root coverage can be very successful. Conversely, implant prominence is just as bad. We all know that if you place an implant toward the facial, you're going to get recession, okay? The same thing is true with implant. So if you have an implant that is outside of the alveolar housing, outside of the restorative envelope, you see, this is the restorative envelope for that. These implants are clearly outside. There's going to be recession, okay, that you can see with those, okay? So that's the issue that we see with that. So I'll show you an implant case with so there's a patient who has very thin bone. You see that the bone is really thin. In some areas there are fenestrations, small areas of dehiscence. The patient has had some recession in these areas of dehiscence. So this patient is prone to recession, very thin bone. So what are we going to do? We're going to extract the tooth very gently in a way not to have the bone damaged. And then we have the socket. We can perform a vestibular tunneling to get access to the area. We use the vestibular tunneling procedure. You can see the fenestration of a periapical lesion. And the implant is placed more toward the palatal positioning. And we're using that tuberosity tissue to increase the tissue thickness to avoid the tissue loss that we're going to have. And you can see, even though we didn't really make it bulky. This is the immediate provisional that was made. We don't fill the embrasure space, okay? But the benefit here is that we did not make any incisions around the papillae. We didn't make an incision around the midfacial, and we were able to get coverage of that. So that's during the healing. And you see that the tissues filled in nicely. And then later we will switch the abutment to a customized abutment, and the tissue is very stable. And we see after 3 years, the tissue contour, that phenotype modification therapy works, and we are creating a nice contour. Now the socket, we filled it in with a xenograft material that is slowly resorbing. So you can see it's very stable. And here we have the also a marginal bone around the implant, very, very stable. So I just want to kind of summarize this to show that with VISTA, it gives us a window. The window allows you to visualize if you have, roots that need guided tissue regeneration. You can see the calculus, you see the intraosseous defect to correct it. You can clear the periapical lesion. You can even place implants through these vestibular tunnel. You can work around implants that have had recession defects to visualize the whole implant. You can use that area to harvest bone. You can use the area for GBR or block grafting and so on. So the vestibular tunnel gives you a very nice access. So just to remind you, what are the principles of regeneration? We need to have a biological scaffold. We need to create a protected space for that scaffold so the scaffold is not collapsed. We need to have a good blood supply to the area. And we need to have a very stable environment for the healing process. So we have very good scaffolds that are biological, and we have to use a technique that allows us to have this kind of all of these, bring them together. And I believe that VISTA is a very useful technique that allows us to respect all of these elements necessary for tissue regeneration. With that, I appreciate your attention. I'm happy to answer any questions that you have, Omid, and I look forward to hopefully this pandemic being over and seeing my colleagues and friends around the world at some kind of a real meeting rather than a virtual meeting.
Thank you so much, Homa. Thank you so much, because, like always, you presented very, very thoroughly and beautifully. And, I have to say, when you introduced VISTA to the world in treatment of gingival recessions, I think it was very unique, and it opened so many doors in so many treatments, as you said, and you showed in your last slides, in GBR procedures, in treatment of peri-implantitis cases, in intrabony defects. And it is actually a very, very unique approach. And me personally have experienced it and really liked the technique. And actually, I also really wanted to compare it to subepithelial connective tissue graft with the coronal approach, as you said, one of the very routine procedures in treatment of gingival recessions. And believe it or not, I really got the point that you said in the beginning of your presentations. It's for the patient, it's much, much more acceptable. From the aesthetic point of view, I can say that not all the surgeons are doing the incisions very, very delicately. So from the aesthetic point of view, we can say that it can be superior. For me personally, I don't compare myself with Giovanni Zucchelli, but when we want to say overall, comparing to all the dentists around the world, really that technique, VISTA, you know, uh, from the aesthetic point of view and from the patient comfort, it's really different. And I have some questions regarding the technique, and I think maybe it's a common question for all the audience watching this now. One of them is that sometimes we don't have recessions with even depth. For example, one of the cases that you also showed with two central incisors that had deep recessions, but the laterals or the canines had the shallower one. In such cases, when we want to do VISTA, because the level of coronal advancement from that incision is different, do we have any concern regarding the folding of the tissue in some areas more than the others, or also any concern of leaving some part of connective tissue or any other matrices there exposed?
Okay, so thank you very much for nice words. I appreciate that. Um, in general, I would say that, first of all, regarding my contribution with VISTA, I don't want to take all of the credit for that, because especially when it comes to the vestibular tunneling for bone augmentation, many others precede me, Fuad Khoury, Michael Block, those are the ones who really introduced the vestibular tunneling for bone augmentation. So even though I call VISTA when I do it, they've been doing it actually before I did for bone augmentation. So they deserve the credit for that. Regarding when you have uneven tissues, like such as this case, right? So you can see that some of the tissues are higher, some of them are lower, but when the vestibular, you see that this is done, the tissues can be harmonized. And in this case, maybe there was a little bit of folding form, and primarily it's because I did not elevate enough. At the time, I was using my older instruments that did not have a really good papilla elevator, but I recommend to completely overcorrecting and bringing the tissues over that. Now, I know many colleagues disagree with that. I know many colleagues are basically teaching the technique of leaving connective tissue exposed. I disagree with that, okay? I think that, if you are leaving that exposed, the reason we're getting more than 100% root coverage is because you see the roots are above a more coronal than the CJ. The CJ up here, we're bringing the tissues 2 to 3 millimeters coronal to that. So I don't think you can get more than 100% coverage if you leave connective tissue exposed. Also, you have to be very careful with what kind of tissue you leave exposed. The only tissue you can leave exposed is palatal tissue. Even the tuberosity is not a good tissue to leave exposed, because tuberosity is not a highly vascularized tissue. And if you leave tuberosity exposed, it can become necrose. And especially where we're going for maximum tissue augmentation and phenotype modification therapy, you cannot go for maximum phenotype modification if you have still some of the tissues are remaining apically and you just have tissues that are growing in there. So I think it's just different philosophies. Obviously, many great clinicians, other alternative approaches that work in their hand. Many people are using the technique of leaving connective tissue exposed. Marcus Hertzler routinely leaves connective tissue exposed. He's a fantastic surgeon, gets excellent results. Zucchelli mentioned, he gets excellent results with coronally advanced flaps. So this is not the only way. I just presented to you, this is what I would see that has many advantages. If you want to adopt it, it's your choice. There are other techniques out there, and clinicians are free to choose whatever works for them. But be aware of the advantages of this particular technique.
Exactly. And Homa, when we want to do use this approach in treatment or modifying the phenotype on implant surfaces. And especially in some cases that by any error, some dehiscences happened, or we can see the prominence of the implant surface through the tissue. In those cases, when we want to prepare this tunnel with this VISTA approach, do we have any concern touching the implant surface with our instrument? Is it because definitely we have some tissue attachment on that exposed implant surface underneath the tissue. So should we be cautious enough to not touching that implant surface, or if we touch that implant surface, doesn't make any difference because we don't want to grow bone on that and we just want to thicken the tissue? So what's your comments on that?
Okay. So when you have exposed implant surfaces, if you have just a facial dehiscence, okay, I think I'm thinking about tissue augmentation, not bone augmentation. If you have intraosseous defects around the implants, those are the ones that are amenable to bone augmentation. Now, this last week was the AAP virtual sessions, and some of the speakers were talking about not touching the implant surface at all because they were saying that there's connective tissue on the implant surfaces. We can't be sure of that. I think that if I'm doing a VISTA, vestibular tunneling, and I see some exposed implant surfaces, typically I would perform odontoplasty or implantoplasty and flatten those implant surfaces. So I would recommend, when you have a vestibular access, you have a very good way of fully accessing that whole area and visualizing the vestibular tunnel. So here's an implant. You can see that you'll be able to fully visualize that area and have access. So if there are threads exposed, you can flatten it, smooth it, make sure that it's completely contaminated to the best that we can. And typically for those, I would prefer to put a very thick tissue graft and perform phenotype modification around implant.
And can we place our graft without doing the implantoplasty? In cases that we have dehiscences for bad implant positioning and we know that it's not contaminated, but just to thicken the tissue, just to make sure we don't see any discoloration through the tissue.
This is the implant that had really, you see that heavily exposed, right? You could see in this particular case, I basically exposed the area of the implant, and then when I exposed it, there are no threads exposed. Mm-hmm. The implant was just placed super facial, right? Yeah. It's just very facially exposed. So now I took tuberosity tissue and then we placed the tuberosity tissue right over the implant surfaces, okay, to get them exposed. So we're able to place the tuberosity material graft over the area to mediate augmentation. So you see, we put it in there and we are submerging the implant. So if you submerge, you're able to get maximum thickness gain and maximum coverage. And you see, we're able to get a good contour of the tissue in that. So compared to where the patient was to where she is now, it gets a major improvement.
Yeah. And Homa, speaking of doing the same approach in the mandible, when we are working in the area of premolars and we have the concern of mental foramen, Um, how do you deal with releasing the tissue in that specific area? Knowing that, for example, we put our incision 1 or 2 teeth before or after that area, but when we are going through the area to release the tissue, do we see any concern about it? Because some practitioners ask about it, so we want to know what's your idea.
That's a very important point. Yes, in the maxilla, basically when we're doing our vestibular tunneling, there are 3 phases that we're performing that. So when I showed this here for the vestibular tunneling, we are basically making the vestibular tunnel going straight across under the non-attached tissue part of the vestibule, and then going under each papilla. In the mandible, what's different is that we don't do any kind of direction. What we will go, the incision positions are always anterior of the canine. Okay, so even if we're treating posterior mandible, the incision position is between canine and lateral incisor. Okay, and from there we will go directly with the instruments under attached gingiva. And when you go under attached gingiva, the dissection is carried out only under attached gingiva. The dissection never goes directly into the vestibule. So you direct your instrument up under attached gingiva and advance it under attached gingiva, and that's a very safe maneuver.
That was a great point. That was a really great point. And you know, you talked also about the importance of elevating the papillas in VISTA approach to prevent the folding and make sure we can completely augment the contour. Is it okay to do intrasulcular incisions and do the intrasulcular incisions and VISTA approach together to make sure that tiny papillas are completely released and we can elevate them more easily, or you don't recommend to do any intrasulcular incisions and going only through the VISTA incision?
I don't recommend. Exactly. I don't recommend doing the sulcular incision, because when you're making sulcular incision, you're going to traumatize the tissues. Mm-hmm. These tissues, when you're going through the sulcus, because the angle of the instrument, the way that the roots are located, the angle, if you open the angle a little bit, it's going to tear the tissue. It's really not necessary, because if we go through the vestibular side with our instruments, we can go through the sulcus, but from a vestibular side through the. So the moment you perform the vestibular tunneling, you will see bleeding occurring through the sulcus, means that we connected to the sulcus of the teeth. So it's better to go from vestibular side toward the gingival margin rather than from the gingival margin up to avoid any trauma to the tissues.
Yeah. And you know, when we are talking about maxilla and when we are doing like full mouth tissue advancement in VISTA approach, so we have an incision in the midline and, for example, 2 incisions in the posterior part. Can you tell us that positioning these incisions in the posterior part, how far they should be from the last tooth that we want to do the advancement of the flap on that? For example, if I want to do a coronal advancement on the second premolar, the posterior incision should be 1 tooth or 2 teeth behind it, or it can be exactly at the area of the tooth that I want to do the advancement.
My suggestion is just to put it anywhere that's convenient for access. Mm-hmm. There's no rhyme or reason where you place it. So typically I would place it anterior of the canine, and from there I can go all the way back, okay? Like you see here, from anterior of the canine, we can go back. But if you don't have any incisions near there, you can be closer to the area that has recession. Sometimes the recession is limited just to the molar. You can make an incision just anterior of that area. And because the incision is apical enough, it's not going to affect that area. The only important point is that make sure the incision is no closer than 5 millimeter to the gingival margin. Because when you make the incisions close to the gingival margin, as you're doing the elevation, you can rip that tissue. So as long as it's apical enough, it could be even right over a root. We're using this also with, let's say, SFOT with orthocorticotomy. With that, I find that I need to have it right over the root. Same with guided tissue regeneration. I keep it very close to the area that has the defect. So you can keep it right over that area and there's no problem because it's apical enough.
Yeah, that's great. And you know, I have to say, me myself, I really learned a lot talking with you about this technique, because you know, so many things opened up also for me during this presentation. And really thank you for your time. But I just want to have my last question, and that's about the matrices that we use in this technique. You talked about dermal graft, like mucograft or mucomatrix, or so many things that you presented, or we can use PRF, or your very first approaches that you don't recommend now, like collagen membranes. So I want to know, is it important to use a slow turnover rate material, or for example, people can also use like collagen sponges doing this technique just to make sure they fill up the space and make the tissue stable, or the type of the material or the turnover rate is the key in this procedure?
Yes. Yes. So for different people practicing different parts of the world, the material is not uniformly available in every country. In some areas, some of the biomaterials are not available. So I would not recommend collagen sponge, because collagen sponge is just loose collagen fibrils that will resorb within 2 weeks. So definitely material that's going to stay around longer is better, because as the material is staying longer, tissue infiltrates. So what distinguishes barrier membranes from matrices and scaffolds is that barrier membranes are cell occlusive, things don't get into them, but scaffolds and matrices are cell permeables. Cells can enter into them. So you want the material to stay long enough so cells can permeate into that, so when the matrix eventually resorbs, that infiltrated cells will remain and maintain the thickness of the tissue. Mm-hmm. So dermal matrix is available in many countries. Human dermal matrix in some countries, they don't have that. In Europe, some areas are restricted with human material. In Europe, I think they have some of the porcine dermal matrix. They have some animal dermal matrix, or they have some collagen. And I know in some countries, porcine material are taboo, so they're not really used. So you have to just go with whatever material that's available to you, but something that stays around longer.
But Homa, comparing collagen sponges with PRF, because PRF also doesn't stay very long. So what's the difference between PRF and collagen sponge that makes PRF works better? Because we have also, a good introduction of that by Amir Alam, one of your previous students in USC. So I want to know, how do you compare the timing of the resorption between PRF and collagen sponges, and the way that work and you think it doesn't work?
Well, the PRF is also very slowly resorbing, but PRF is a biologically active material, and it actively recruits much faster cellular elements. It basically recruits a lot of neovascularization. It recruits a lot of tissue infiltration. So it's much more active to bring things into the area. But typically, personally, for me, I will not use PRF as the only material either. I use PRF, but usually I use it in conjunction with either a collagen matrix that's slowly resorbing, or in conjunction with some kind of a dermal matrix that's resorbed, because you get better thickness gain with that.
Yeah, yeah. Well, Homa, really thank you so much for sharing your valuable time with us. It was for me truly a pleasure, and really, really, really looking forward to see you very soon. And hopefully, I don't know what will happen in 2021, but for all of our audience, for the next Symposium of Complications in Implant Dentistry, it is supposed to be in 2021, but hopefully it happens the way it should be. Dear Dr. Zadeh going to be one of our keynote speakers, and really looking forward to that day this pandemic ends, and to be your host in Iran, and really looking forward to see you very soon anywhere in the world. And really thank you again for accepting and for your time and this valuable information.
Well, Omid, I just want to congratulate you for all the great work you're doing with all the educational events that you're organizing, and still also contributing to education, being in the faculty of the university, and doing really great work. So my hat off to you. Stay healthy, stay well, and hope to see you in person soon. So all the best to you and your family.
Thank you so much. Stay safe, my friend. God bless you. Take care.
Thank you. Okay, thank you.
Bye-bye.
Bye-bye.